Okay, so today we're going to start talking about myocardial diseases. So we'll start with this case. So we have a 37-year-old with chest pain and elevated cardiac enzymes. So first of all, what kind of views do we have here? What kind of view is this on the left? That's a short axis view, right? This guy over here. Yeah, that's a four-chamber view. Ejection fraction is 52%, so, I mean, it's not terrible, maybe very mild hypokinesis, but not really much else to see here, okay? So then we go on, and what are we thinking about with this history? So we have somebody with chest pain and elevated cardiac enzymes. What's the first thing that comes to mind if somebody presents to the ER with chest pain and elevated cardiac enzymes?
MI.
An MI, right, so myocardial infarction, right? So we go on to do this. So here we have a T2 weighted image, short axis. Here we have post-contrast, short axis. And what kind of view is this over here? Well, how many chambers do we see? Two chambers, right? So that's a two-chamber view, right? So what's abnormal on the T2 weighted image? What are we looking for on T2 weighted images? What do we look for? No, there's no motion here, right? It's a still image. Your T2 weighted images, you're usually looking for what? Usually looking for edema, right? So do we see any areas of high signal here on this T2 weighted image? In the myocardium. Well, back here, right, along the inferior wall, we have this area of higher signal, right? So we do have some edema there, okay? And on the post-contrast sequences, do we have any areas of abnormal enhancement? Particularly, look where we have the edema, right? So we do see abnormal enhancement in the same region, right there. So the first thing you were thinking about was myocardial infarction. So is this a myocardial infarction? Jose says no. Why not? Yeah, the endocardium is spared, right? So with myocardial infarction, it should involve the endocardium. Here the endocardium is spared, so this is involving the epicardium. So with the history of chest pain, elevated cardiac enzymes, edema, and this enhancement pattern, what do you think this is, Jose? Myocarditis, right. Acute myocarditis would be your diagnosis here, okay? So let's talk about myocarditis. So commonly it's caused by viral infections. There are other infections that can also cause it. There are non-infectious causes of myocarditis also that I've listed here. Sometimes drugs can do it, toxins, even radiation therapy. So myocarditis represents non-ischemic inflammatory disease of the myocardium. So patients can present with chest pain, weakness, palpitations. In most cases, they recover spontaneously, although it can be responsible for up to 12% of sudden deaths, especially in young patients. And as a complication, most patients recover, but some patients can develop the complication of dilated cardiomyopathy after myocarditis. So for definitive diagnosis, you would need a biopsy, but you don't really want to do that, so it would be nice if we can make the diagnosis with other imaging modalities like MRI. So what happens with acute myocarditis is initially the patients will have edema in the myocardium and myocyte injury. At this stage, they have decreased systolic function, and then as it progresses to subacute myocarditis, the edema goes down, but fibroblasts proliferate, so they can start to develop here, even though the function may improve, they might develop some fibrosis. And then the sequela, most patients recover, although they may have areas of residual fibrosis. A small percentage of patients, 5% or less, go on to develop the complication of dilated cardiomyopathy. And then here they will not have edema, but they will have decreased cardiac function and will have fibrosis, diffuse fibrosis or focal fibrotic areas in the myocardium. To make the diagnosis of myocarditis with MRI, there's the Lake Lewis criteria. So this applies to symptomatic patients with clinically suspected myocardial inflammation. So this is not for screening of asymptomatic patients. So these criteria are for symptomatic patients. You can see the sensitivity and specificity. So you need one category, one criteria from each category to fulfill the criteria for making the diagnosis. You need a T2-based marker of myocardial edema that tells you there's edema and acute inflammation, and you need a T1-based marker of myocardial damage. If you only have one positive criteria, that can still support the diagnosis, but the specificity is not as good. So what are these criteria? So for a T2-based marker of myocardial edema, you might have edema on T2-weighted images, or you might have prolonged T2 time if you're doing T2 mapping. T1-based marker of myocardial damage, the most common thing is to look for abnormal enhancement and a non-ischemic pattern, or you might have elevated T1 times on T1 mapping sequences, or you might have elevated extracellular volume fraction. So in most cases, we look for this. We look for delayed enhancement or elevated T1. So here's an example. So there might be wall motion abnormalities and systolic dysfunction at presentation, although that usually returns to normal after recovery. So here we see high T2 signal, right? So that's the edema. And then if you do T2 mapping, there will be these areas of abnormal T2 times, usually correspond to areas of edema. And then on myocardial delayed enhancement, your T1 criteria, you have abnormal myocardial enhancement in a non-ischemic distribution. So that's what you look for. Or you might have elevated T1 times if you're doing T1 mapping. So those are the findings that we look for. So here's another example, 31-year-old with viral myocarditis. We can see some edema on the T2 weighted images, abnormal enhancement. So the native T1 time will be increased, so some areas of abnormal T1 times in there, and then the same thing with the native T2 times. Now 5 months later, what happens is that the areas of enhancement go away, although there might be some residual delayed enhancement representing some areas of fibrosis, okay? The edema, though, also goes away, so there's not going to be edema when you're in the chronic stage. When you have fibrosis, you might have elevated native T1 times, okay, but the T2 times should be normal because we don't have edema anymore, all right? The adverse prognostic indicators, the extent of myocardial enhancement, the more enhancement you have, the worse the prognosis. MDE without edema, so that usually is worse because that indicates that there's fibrosis there. It's worse than MDE with edema. And then if the ejection fraction is low, of course, that's also a bad prognostic indicator. And high native T1 times and extracellular volume fraction, so all of that are indications of fibrosis and are bad for prognosis. So we can see abnormal enhancement in a distribution that is not typical of ischemia. So here you have mid-myocardial enhancement. We also have enhancement in more than one vascular territory. So all of that goes against myocardial infarction as being the cause of the abnormal enhancement in these cases of acute myocarditis. And then here you can see the curves of depending on when the late gadolinium, when you have late gadolinium enhancement. So when you have it, the prognosis is worse. So your survival curve to a cardiac event gets worse the more enhancement that you have. So it's important to quantify the amount of enhancement that you see in these cases of acute myocarditis because that is related to prognosis in these cases. So let's go over the patterns of enhancement that we might see. So for myocardial infarction, it should involve the endocardium because the endocardium is the most ischemic area of the myocardium. So for myocardial infarction, we want the enhancement to involve the endocardium, and it should be in a vascular distribution. So this particular enhancement here is in what vascular distribution? LAD, right. Now what about this dark area here? Is that viable myocardium or is that something else? So what did we say that was? That's microvascular obstruction, right? So that, what does that tell you about the age of the infarct? Yeah, it tells you it's an acute infarct. So if you have an infarct with an area that's not enhancing, that's the core of the infarct. So that is really necrotic myocardium. So, and then that does not enhance because of microvascular obstruction associated with the infarct. So the gadolinium does not get into that region, okay? As opposed to myocarditis, where you can have mid-myocardial enhancement or epicardial enhancement that spares the endocardial surface and will also be in a non-vascular distribution. So you want to differentiate abnormal enhancement that you'll see with infarcts versus abnormal enhancement that is not related to ischemia. So in myocardial infarction, it starts in the subendocardial region and then progresses to the epicardium. So whenever we see delayed enhancement, it should involve the endocardium in cases of myocardial infarction. So it might be partial thickness, it might be full thickness, but it should always involve the endocardium. So here's another example, very small area of infarct here, but it does involve the endocardium. What might cause this? Very small area of infarct like that. What might cause that? No, this is an infarct. This is not from a non-ischemic cause. Embolization, small emboli, right? If there's an emboli causing infarct, you might have small areas of infarct like that, okay? Or it might be transmural, as in this example, right? So it's involving all of the myocardium there. So non-ischemic patterns, mid-myocardial enhancement, that is a non-ischemic pattern. Epicardial enhancement or diffuse enhancement, those are non-ischemic patterns of abnormal myocardial enhancement. Okay, so here's an epicardial enhancement. So this is sparing the endocardium. So this is not from ischemia. So this is a non-ischemic cause then of myocardial injury. And then, of course, you might have diffuse enhancement. Of course, that's not going to be ischemia either, or the patient would not be able to survive ischemia of the entire heart. Okay, but there is a disease that can result in diffuse myocardial enhancement that we're going to get to a little bit later. Okay. Acute viral myocarditis, so this can give you edema like we see here, and give you a non-ischemic pattern of delayed enhancement. So that's what we see with acute myocarditis. Now, there is something called infarct-like acute myocarditis, where the patient will have presentation just like myocardial infarction, chest pain, ECG changes, elevated enzymes, edema. We'll see edema on your T2-weighted images, and it usually corresponds to the areas of abnormal enhancement. But it's this pattern of abnormal enhancement that tells you that this is not ischemia. Here it's mid-myocardial, it's sparing the endocardium, so it tells us that this is a non-ischemic cause of myocardial injury. Here's an example of acute myocarditis here, and then 3 months later, you can see that a lot of the delayed enhancement has resolved, although there do remain some areas of abnormal enhancement, and that might correspond to fibrotic regions within the myocardium as they develop fibrosis as a sequela of the myocarditis, of the acute myocarditis. Okay? So let's move on to cardiomyopathies now. So what do we see with cardiomyopathies? Well, what do we think of the size of the heart? Yeah, it's enlarged, right? So you have dilated ventricles, especially the left ventricle, and what do you think of the wall motion? Hypokinetic, right. So a dilated heart with hypokinetic wall motion. So that's usually what you see with a cardiomyopathy. There are two broad categories of these dilated cardiomyopathies, right? So what are the two broad categories of dilated cardiomyopathy that MR can help distinguish between? What are they?
Ischemic or non-ischemic?
That's right, ischemic or non-ischemic, right? So is the cardiomyopathy secondary to ischemia or is it a non-ischemic cause of myocardial injury? Right? So ischemic versus non-ischemic cardiomyopathy, especially dilated cardiomyopathy, is what we're trying to differentiate. Now, how can MRI help us differentiate these two? What is the sequence that is going to be most valuable for us? Delayed enhancement. So how is that going to help?
So we can see the type of enhancement that we have.
Right. So for an ischemic cardiomyopathy, what kind of enhancement should you see?
So myocardial and
Right, exactly right. So it's usually a sequela of infarction, right? So of ischemia. So we're going to look for that subendocardial enhancement in vascular distributions, as opposed to non-ischemic causes where you might have no enhancement, or you might have enhancement in that is a non-ischemic pattern of enhancement, like we have reviewed. Okay, so here's that particular case that we're looking at. So here's our myocardial delayed enhancement here, okay, for that particular case. Is this ischemic or non-ischemic? Non-ischemic. Why? Yeah, so it spares the endocardium, right? And you can see that it's predominantly in here. On what kind of view is this? Two-chamber view. This is a four-chamber view. These guys are short axis view. So we can see that the enhancement is predominantly what we would say, what pattern? Epicardial, right. So it's predominantly epicardial enhancement. It's sparing the endocardium, okay? So that's not what we would, and it's more than one vascular distribution here. So this is not what we would expect to see with infarction or ischemia. So this has to be a non-ischemic cause of myocardial injury. This might be a sequela of prior myocarditis, although we'll talk about other diseases also that might give you non-ischemic patterns of abnormal enhancement that can lead to cardiomyopathy. Now there's a classification of cardiomyopathies depending on what textbooks you look at. Primary have no known cause, secondary have known causes, and then they're unclassified. So the primary cardiomyopathies, idiopathic, hypertrophic cardiomyopathy, arrhythmogenic right ventricular dysplasia, and then a lot of things can result in restrictive cardiomyopathy. Secondary cardiomyopathies, there are many things that can lead to these secondary cardiomyopathies. There are metabolic disorders, all of these things that I've listed here, hypertension, systemic diseases like sarcoid connective tissue diseases, ETOH, right? So that's a cause, alcoholic cardiomyopathy, even muscular dystrophy for neuromuscular diseases. We talked about infections, sequelae of myocarditis, X-ray therapy, and also a common cause is postpartum cardiomyopathy. This is something that we do often see, is postpartum cardiomyopathy as a cause of secondary cardiomyopathy. And then there are some unclassified cardiomyopathies. Some of these we'll also discuss. All right. So what happens with dilated cardiomyopathy? Of course, it impairs contraction of the ventricles, especially the left ventricle. Ejection fraction is low. The ventricle increases in size. The end diastolic volume increases. And what happens is, as the ventricle gets bigger, that causes abnormal wall stress and abnormal stress on the myocytes, which causes death of myocytes, which then results in worsening of function, which causes more dilatation, and you get into this vicious cycle there. So this dilated cardiomyopathy can be a final morphologic outcome of a variety of biological insults. We've talked about the various reasons that can cause damage to the myocardium, and we talked about as the left ventricle dilates, it causes abnormal stress on the myocytes, which can accelerate the dysfunction and the death of myocytes. So myocardial dysfunction begets myocardial dysfunction. This is called adverse ventricular remodeling. As the ventricle dilates, it remodels, and then that causes basically a vicious cycle. Okay? Four-chamber dilatation. As ventricles dilate, you can develop regurgitation of the tricuspid and the mitral valve, especially from papillary dysfunction, also from dilatation of the annulus for these valves, diffuse contractile abnormalities, and what happens is the regurgitant fraction, because of the poor ejection fraction, is not a great deal. So the atria don't enlarge really that much. Another problem because of the stasis of blood flow is mural thrombi. So mural thrombi can also be a complication of dilated cardiomyopathy. What do we see on the chest radiograph? Big heart, right? No mystery there. Pulmonary vascular changes may be mild, out of proportion to the heart size. But so if you come across a young person with a big heart on a chest radiograph, the next test you're going to recommend is echo, because the two things in your differential are so cardiomyopathy and cardiodiffusion, right? Those two things are in your differential, so the next step is going to be echocardiography if you come across a young patient with a big heart on a chest radiograph. Right? So we talked about dilated cardiomyopathy. This, of course, is what kind of view? LVOT or three-chamber view, right? So now, what are the patterns we can see in these kids? This is a study that's from quite a while ago, but it's a study that is quoted in textbooks and articles that you will read on this. So with ischemia, if we have ischemic dilated cardiomyopathy, that's usually secondary to coronary artery disease. So all of those, so in this particular study, what did they do? They looked at patients with dilated cardiomyopathy, and then all of these patients had cardiac caths. And those patients who had abnormal stenosis or high-grade stenosis on their cardiac cath, they were classified into the ischemic group. Those that did not into the non-ischemic group, who didn't have any flow obstructive lesions, were in the non-ischemic group. That was their gold standard. And all of these patients had MRI. And they looked at what was the pattern of enhancement that we saw on MRI. All of the patients that had severe obstructive coronary artery disease, all of them demonstrated abnormal enhancement, and you can see that the abnormal enhancement was in an ischemic distribution. Okay. Now, what happens to those patients who did not have significant obstructive coronary artery disease? Most of them had no delayed enhancement. So most cases of non-ischemic dilated cardiomyopathy, most of those patients will not demonstrate abnormal enhancement on MRI. That's still useful because that tells you that it's not an ischemic cause of their dilated cardiomyopathy. A small percentage, let's get to that group last. The second most common group was a group that developed mid-wall or patchy delayed enhancement, right? A non-ischemic pattern of enhancement, which is usually a pattern that we see as a sequela of viral myocarditis, okay? So this group that you can also see, again, this is a non-ischemic pattern of delayed enhancement. It's a cause of non-ischemic cardiomyopathy. A smaller percentage, though, did have delayed enhancement that was indistinguishable from ischemic cardiomyopathy. So they had delayed enhancement in a vascular distribution involving the subendocardium. So their interpretation of this was that these were patients who did develop dilated cardiomyopathy as a sequela of ischemia, but for whatever reason, at the time they got their cardiac cath, they did not find obstructive disease. Either they recanalized the coronary artery, or it may have been a thrombus that recanalized. So that was their interpretation of how they explained this finding. But the take-home message is that MRI, depending on the pattern of enhancement, can help us to distinguish ischemic from non-ischemic causes of dilated cardiomyopathy. Okay? The cardiomyopathies that tend not to show delayed enhancement, idiopathic alcoholic postpartum. So these are very common non-ischemic causes of cardiomyopathy. These usually do not give us delayed enhancement on MRI. So it's not surprising on MRI if we don't have delayed enhancement with these cases. Right? Those that show delayed enhancement, those are more typical of sequelae of viral myocarditis. Okay, so those are more likely to show delayed enhancement. The good news is that using T1 mapping is more sensitive than myocardial delayed enhancement for looking for myocardial abnormalities. So that can also help you to find these cases of abnormal myocardium. So the issue with delayed enhancement, if you have focal areas, very focal abnormality like you might see, regional disease, very regional disease, like you might see with the myocardial infarction, right? then it's pretty easy to find the area of delayed enhancement, because what we do is we suppress the signal from the normal myocardium, and then that abnormal myocardium really stands out against the normal myocardium. The problem is, in these cases of non-ischemic cardiomyopathy, these patients have diffuse abnormalities of the myocardium. They can have diffuse fibrosis of the myocardium, and then there, when we try to suppress the signal from the myocardium, we winding up suppressing it. And so we don't see it as delayed enhancement. It can be very subtle, as in this case here, or you might not see it at all. So that is the drawback of using myocardial delayed enhancement, looking for abnormal enhancement to help you to diagnose abnormal myocardium in these cases of cardiomyopathies. It's when they have diffuse fibrosis. We will not see the enhancement because we wind up suppressing all of the enhancement, essentially by suppressing all of the myocardium. Right? So with myocardial infarction, the area of enhancement is usually pretty easy to see, but when you have a diffuse fibrosis from cardiomyopathy, non-ischemic cardiomyopathy, we do not see the delayed enhancement. But this is where looking at native T1 times can be helpful, because here the T1 times, the native T1 times of the myocardium will be abnormal, and so this can help you then say that the myocardium has abnormal T1 times. It's elevated in these cases, so we suspect the patient has diffuse fibrosis. Okay? Now, if there is edema, right, so we kind of covered a little bit of this before, what will that do to the native T1 time? What does edema do to the native T1 time? Does it go up or down? Up, right? Think of water. Water has a long T1, right? What does that do to the native T2 time? Also goes up. Think of water, right? Edema water has a long T1, long T2. Easy way to remember it, right? The ECV, usually pathology does what to the ECV? Up, right? So all of those things will go up. So in the acute phase, if the patient has edema, let's say from acute myocarditis, you would expect all of these to be abnormal. If you're doing T1 mapping or T2 mapping or looking at extracellular volume fraction, all of those will be abnormal, okay? If there's myocardial fibrosis, okay, if there's myocardial fibrosis, what is that going to do to the native T1 time? Up. Pathology usually increases the native T1 time, although there are exceptions which we will get to, right? What happens to the post-contrast T1? Down, right? Pathology usually enhances, right? So it tends to decrease the post-contrast T1. And then when you have pathology, what usually happens to the ECV? Up, right? So the native T1 time will go up, the post-contrast T1 time will go down because you expect there will be enhancement, which will decrease the T1 time. So that's an easy way to remember it. And in pathology, in most cases, especially if there's fibrosis, right, is going to increase the ECV. Okay, in those cases. And then by the color maps, so if you're doing T1 mapping, you look at the color maps. So this is ECV, and then so the color kind of gives you an idea of where it falls, but you'll usually just take a direct measurement, a region of interest, a direct measurement, and that gives you an actual numerical value. And you can do the same thing with your native T1 times, right? So you can look at it, so the software will give you diffuse an estimate of what the T1 time is globally for all of the myocardium, or you can take it for focal regions. If you suspect there are focal regions of abnormality, you can put regions of interest there and measure the native T1 time in those regions of interest. Okay. So myocardial fibrosis increases the native T1, decreases the post-contrast T1, increases the ECV. Okay. All right, so let's move on. What kind of views do we have here? So on the left, we have a 4-chamber. On the right, we have, so an outflow tract or 3-chamber view, okay? So first of all, without giving me a diagnosis, tell me what's abnormal. What? Regurg where? What chamber?
So come back into the left
Into the left ventricle? What chamber is this guy?
ventricle.
It's the left atrium, right? So notice when the ventricle is contracting, we have turbulent flow going back into the left atrium. So this patient has what? What kind of regurg is this? Mitral regurg, right? The patient has mitral regurg. Is there any other flow disturbance that you see in systole when the ventricle is contracting? Yeah, along the outflow tract, right here, right, we also see turbulent flow. That dark signal jet is turbulent flow in that region, right? So that tells us it's high velocity flow there, and there's turbulent flow here, right? So what's going on in this patient now? Is there another abnormality that you see when you look at the myocardium? Do you notice anything else?
Septal thickening.
There's septal thickening, right? So there's thickening here in the septum extending into the outflow tract. So what are we dealing with? What do we have here? Yeah, so this is hypertrophic obstructive cardiomyopathy, where there's hypertrophy of the interventricular septum extending into the outflow tract. That's causing subaortic stenosis in the outflow tract. Why does the patient have mitral regurg? What causes that in patients who have hypertrophic cardiomyopathy, or hypertrophic obstructive cardiomyopathy, as in this case? What causes the mitral regurg? SAM. So what is SAM? Systolic anterior motion of the anterior leaf of the mitral valve. So what tends to happen is that because of the high velocity flow here, it causes the anterior leaf of the mitral valve to get sucked into the outflow tract, which further aggravates the obstruction, but also results in mitral regurgitation. So mitral regurgitation can also be associated with hypertrophic obstructive cardiomyopathy. All right. So these are some of the demographic things you need to know about this. Can be associated with neurofibromatosis, Noonan's, and then this lentiginosis syndrome. Okay. Usually the wall greater than 15 millimeters thick at end diastole without known cause. So should be no hypertension. Often have increased ejection fraction, which you usually think is good news, but is really bad news for these patients, and we'll talk about why. But usually you think that ejection fraction is a good thing, but it's not so good here. The hypertrophy can involve the whole chamber, in which case it's concentric, can involve the free wall of the left ventricle or a segment of the interventricular septum, which is usually the typical form that we see here in the United States. It may involve the apex of the left ventricle, which is more typically the form that is seen in Japan. Okay, so these are the different forms. So here you have asymmetric hypertrophy along the interventricular septum. Here we have concentric hypertrophy. Here there's midventricular hypertrophy, okay, in this case. And then here there's apical hypertrophy. And this apical form can often be associated with that little aneurysm that occurs here at the apex in these patients, okay, because of the apical hypertrophy. So those are the various forms that we might see. Some other terms that are symptomatic with hypertrophic cardiomyopathy. We talked about SAM. What happens is that because of the high velocity flow in the outflow tract, the anterior leaf of the mitral valve can move in, get sucked into the outflow tract. That causes the mitral regurg, but it also aggravates the obstruction there in the outflow tract. So your typical features: high velocity flow along the outflow tract, hypertrophy of the interventricular septum causing the obstruction of the outflow tract, and then the bonus, the mitral regurgitation because of SAM in cases of hypertrophic cardiomyopathy. Now, if you're looking for turbulent flow, right, if that's what you're looking for, notice that it's much more obvious on the second sequence than on the first sequence, right? So what's different between these two sequences? Anybody have an idea if you're looking for turbulent flow? How might you sensitize the sequence to the turbulent flow? What's different about these two sequences? What? Yeah, this is spoiled grass. This is PS, this is SSFP, okay? So what happens is, SSFP is the usual sequence that we use when we're doing cardiac imaging. It gives you a very nice contrast between the blood pool and the myocardium. But if you're specifically looking for turbulent flow, this can be more sensitive to it. It has a longer TE time, which helps, right? The longer the TE time allows more time for dephasing when you have turbulent flow. So that will sensitize the sequence to turbulent flow. So if you're specifically looking for valvular abnormalities or turbulent flow, the spoiled grass, the cardiac gated spoiled grass sequences are going to be more sensitive to that than your SSFP. Now, having said that, it's in clinical practice, it's usually not an issue, although occasionally it might come up. So just remember that you can switch to this sequence if you're trying to figure out, I think there's some turbulent flow here. Can we see it better? Well, then you might move to this sequence. Okay. Now, you can have delayed enhancement in these cases of hypertrophic cardiomyopathy, usually in where the abnormal hypertrophy is, because these patients do develop fibrosis in these areas of abnormal hypertrophy. What is the significance of this? Well, what's the most common cause of death in patients with hypertrophic cardiomyopathy? The most common cause of death is arrhythmia, right? Arrhythmia. So these can be arrhythmogenic foci. So these areas of abnormal hypertrophy can act as arrhythmogenic foci, and a delayed enhancement, if there's fibrosis in there, that can make it worse. So these may act as areas of foci, arrhythmogenic foci. Okay, and it's common to see abnormal enhancement there in that region at the junction there of the right ventricle with the interventricular septum there, that junction region. Okay. Factors associated with increased mortality and diastolic wall thickness. So what happens is for these patients will get a defibrillator, right? If they have features on MRI that are high-risk features, those patients will get a defibrillator to prevent sudden death, okay? So the end diastolic wall thickness, to make the diagnosis, we use 15 as a cutoff, but if it's greater than 30, then it's really severely hypertrophied. If there's a large amount of delayed enhancement, apical aneurysm, if the gradient, which you can measure using phase contrast MR, is greater than 30 millimeters of mercury, enlarged left atrium, if the ejection fraction is low. So these are high-risk features on MRI in cases of hypertrophic cardiomyopathy. So with hypertrophic cardiomyopathy, what do we expect to see with the native T1? See it there. What does pathology usually do to the go up? The post-contrast T1, go down, right? And the ECV, yeah. So you can see on the delayed enhancement there, so the native T1 is high, right? The yellow is is indicating a high value, and that's where you're getting the delayed enhancement here also. And then after contrast, it actually goes down, which is why it's dark, okay? So up, down, up, all right? So that's what we see with hypertrophic cardiomyopathy. T1 weighted image here, this is a T2 weighted image, this is myocardial delayed enhancement. So first, what are the findings here? And then what was done for this patient? So this patient underwent a procedure. What was the procedure? So first, what are the findings? On the T2 weighted image, we see, well, first of all, on the T1 weighted double IR inversion fast spin echo recovery image, what's wrong with the myocardium? Yeah, so it's hypertrophy, right? So it's a patient with hypertrophic cardiomyopathy. What do we see here on the T2 weighted image? Yeah, so there's this area of hyperintense signal, hyperintensive, and what does that mean? That there is edema, right? Notice the center of it looks a little different. And what do we see on myocardial delayed enhancement? Well, so most of this enhances, but there's this central area that does not enhance, right? So what happened to this patient? So the patient underwent an ablation procedure, so the hyperenhancing area represents what? The enhancing area is what? Well, what's the idea with the ablation procedure? What are they doing?
Killing tissues, right?
They're inducing an infarction, right? So that area, this is all infarcted myocardium. What's this area that is not enhancing?
Microvascular.
Yeah, microvascular obstruction. So that's the core of the infarct, right? So this patient underwent an ablation procedure, so this is one option in patients with hypertrophic cardiomyopathy if it's obstructing the outflow. And then the idea is to induce an infarct, and then after the infarct, that area will atrophy. And then that atrophy then relieves some of the obstruction in the outflow tract. Okay? So you can see pre-ablation here, post-ablation, there's a little bit less myocardium there in the outflow tract because of atrophy as a result of inducing the myocardial infarct. Right? So this is one treatment option. The preferred option is surgery if it's actually causing obstruction, but this is another option as an ablation procedure. And then here's an example of that. So you can see here this hypertrophy in the outflow tract causing subaortic stenosis. Or then immediately after the ablation procedure here, you can see the enhancement where the ablation was performed. So that's the infarct. And then almost a year later, once there's atrophy, you can see it relieves the obstruction there of the outflow tract. And you can see there's been atrophy, although there's still enhancement in the region of the infarct. Okay? Now, one thing that is also can give hypertrophy, especially in young patients, is athlete's heart. So in very well-trained athletes, these patients can have some left ventricular hypertrophy, although it still tends to be less than 16 millimeters, which is the cutoff that we use for hypertrophic cardiomyopathy. But there may be some overlap here of athlete's heart versus hypertrophic cardiomyopathy in terms of in terms of the amount of hypertrophy that you would see with echocardiography. What's different in athlete's heart is that even though there is hypertrophy, the volume of the left ventricle is actually increased. So the left ventricle dilates a little bit, so it's actually becomes more efficient at pumping the blood, and there is no diastolic function. So here, when we look at athlete's heart, there can be a little bit of hypertrophy there, okay? But you see in the heart itself, in systole, right, there's still a good amount of volume there within the heart, as opposed to hypertrophic cardiomyopathy. One of the features of hypertrophic cardiomyopathy is this obliteration of the left ventricular cavity at end systole. So remember when you calculate the ejection fractions that it is a ratio, and that's why the ejection fraction can actually go up with hypertrophic cardiomyopathy. It's because of this obliteration of the cavity. So the cavity is being obliterated not because the heart is more efficient at pumping blood, but because of the hypertrophy itself. Okay? And so that is one thing that can help you differentiate between athlete's heart and hypertrophic cardiomyopathy. Although in cases where it's still questionable, they will just ask the person to stop training. And then what happens is that the hypertrophy goes away after a few months of stopping training. But this isn't a differential in young patients, athlete's heart, if they are heart training athletes. Okay. Now, this is an entity that also can give you thickening of the myocardium that is often confused with hypertrophic cardiomyopathy. So this patient has symmetric myocardial hypertrophy that mimics hypertrophic cardiomyopathy. But there's a finding here on the myocardial delayed enhancement that is characteristic for this disorder. First, what's the finding on the delayed enhancement? So the enhancement is mid-myocardial, right? It's in the mid-myocardium there, and it involves the lateral wall. So that feature is characteristic of this disorder. What's the disorder? Yeah, so Fabry's disease. So this is a rare disease. So it's a deficiency of this enzyme, and it results in intracellular deposition of this glycosphingolipid. So that causes the thickening of the myocardium, and often it's misdiagnosed as hypertrophic cardiomyopathy. Complications are arrhythmia, valvulopathies, restrictive cardiomyopathy. But in addition to the hypertrophy, that enhancement along the lateral wall, mid-myocardial enhancement, mid-basal infralateral wall of the left ventricle, up to 50% of patients can be characteristic for this disorder. So what does this do to the native T1 time?
Depends where, like, what process is happening.
So what do you mean by that?
So if it's like the Because both fibrosis and lipid.
We'll start with the deposition of the lipid
So
itself.
lipids of shortened T1.
Yeah, because the fat would shorten the T1, which is the opposite of what we usually think about pathology, right? Pathology usually increases the T1, but then you were getting at something else
Yeah,
too.
then fibrosis also occurs, and that would increase the T1.
Yeah, so if there's fibrosis, then the two things kind of counteract each other, and that's called pseudonormalization, because fibrosis would usually increase the T1. And the ECV, what happens to the ECV?
Doesn't change.
Yeah. So the ECV doesn't change. So the native T1, where there is intracellular lipid, will go up. Will go down because the lipid shortens the T1 time. So you can see here along the interventricular septum that native T1 time is decreased. However, where we have fibrosis, where we have the abnormal enhancement, where there is fibrosis, that works in the opposite direction. And so that can actually increase the T1 time. So sometimes if you have the right balance of both, it can actually be normal. Okay? So this can be confusing, but with Anderson Fabry disease, the lipid itself, if all we have is the lipid itself, that will actually shorten the T1 time. That's the exception to pathology usually increasing the native T1 time. But the extracellular volume fraction is normal since this is an intracellular process. Okay? All right, so here we have a different patient, and what kind of views do we have? There's a short axis view, and this is fourth chamber view, right? Now, so far, well, first of all, what's the abnormality? What's abnormal? Anything look abnormal here? When you look at this heart?
Genetic.
What? Where? Yeah, I can't hear you.
Septal hypertrophy?
Okay, is it just the septum?
No, it's also lateral too.
Yeah, especially the septum, but also some lateral wall. So there's myocardial hypertrophy, right? So there's myocardial hypertrophy. Now, so far we've covered two things, right? That would be in the differential, right? So what are those two things that we've covered already? Right, so hypertrophic cardiomyopathy and Fabry's disease, right? So both of those can cause abnormal thickening of the myocardium, okay? What would you like to see? All right, so move on to see what does myocardial delayed enhancement look like. So what are we looking at here? First of all, what is this? What do those numbers mean on the bottom in yellow? Yeah, so those are inversion times that we're using to try to do what?
Suppress the myocardium.
To try to suppress the myocardium. What's happening? It's not suppressing, right. So this is often the first clue that you're dealing with this disorder. So,
Either like amyloid or sarcoid.
well, which one? Amyloid. Right. So often this is the first clue that you're dealing with this disorder, is that when you're trying to suppress the myocardium, you're having a hard time doing it. Because what's happening is the amyloid deposition causes enhancement, diffuse enhancement of the myocardium. So it's very difficult to suppress the myocardium. Okay. So regardless of the inversion times that we're trying to use here, we're having trouble suppressing the myocardium. So amyloid can give you diffuse enhancement of the myocardium, and the first clue might be this difficulty in trying to suppress it, because all of the myocardium is abnormal here because of the deposition of amyloid. And it can also give you thickening of the myocardium, right, which we can mistake for other diseases like hypertrophic cardiomyopathy. So normally, as we go through the look-locker sequence, as we vary the inversion times from shorter to larger, what normally happens is that the blood pool gets dark at the shorter inversion times first, and then the myocardium gets dark, right? So you'll see the blood pool gets dark at the shorter inversion times, and then the myocardium gets dark at the longer inversion times. That's what you would expect. The blood pool has more gadolinium in it, so it should have a shorter T1, so that should be suppressed easier at the shorter inversion times. So here we're going through some different inversion times. Here at 160, you can see that the blood pool is nice and dark, but the myocardium does not suppress until we get to the longer inversion time at 270 in this particular patient. Okay, so that's normal. That's what usually happens. But with the amyloid, what can happen is that the heart muscle itself has amyloid in it, which causes enhancement. Also, the amyloid is not just within the heart muscle. Amyloid is also deposited all over the body in many of these patients. And the amyloid sucks up the gadolinium. And so the amyloid actually sucks the gadolinium out of the blood pool. And so what can result then is that the myocardium can suppress. The myocardium can get dark before the blood pool. So what happens there? So here's the blood pool is bright here at a TI of 105, at a TI of 140. The blood pool is still bright, but look, the myocardium is now dark, is suppressed, right? And then here, the blood pool does not suppress until we get to a TI of 200 in this particular patient. And then here, the myocardium is bright. So that kind of reversal can occur with amyloid. And so, we talked about the null point, right? So the shorter the T1 time, the null point moves lower and lower when you're doing inversion recovery sequences. So normally the blood pool null point, let's say, is over here where the myocardium is here. So the blood pool suppresses at lower inversion times. But when you have amyloid, that kind of flips. And so then the myocardium can suppress at the lower inversion time in the blood pool. So again, often you first realize that you're dealing with a case of amyloid when you're having trouble suppressing the myocardium. So that's the lesson here. Okay. Now there are different forms of amyloidosis. There's AL amyloidosis, and this is usually related to some kind of a malignancy. This is light chain deposits so this light chain amyloid can deposit all over. And then there's this transthyretin amyloidosis, and this is produced by the liver. But then this also can get deposited. And there are mutations of this. There's a wild type, and there's a mutant form of this mutation of the gene itself. And so here with this wild type, this tends to affect older men, wild type ATTR. Here it's a non-mutated protein, and so that deposits in the heart and carpal tunnel. Here where there's a mutation, where there's a genetic mutation of the transthyretin gene, so here you get amyloid deposition in the heart, nerves, and carpal tunnel. So in older patients who don't have underlying malignancy, there's these two different forms that you might run into. So what happens to the native T1 in cases of amyloid? Goes up. Post-contrast T1 goes down, right? Remember, amyloid causes enhancement. And the extracellular volume fraction
Increases.
Yep. So just what you would expect from pathology, right? So that's what's going to happen with amyloidosis. So you can see here that the native T1 is very high. Here it's measured there. That's what the normal T1 should be. And plus contrast T1, because of the enhancement, it goes way down, but the ECD might be in the normal range. So these kind of infiltrative processes can result in restrictive cardiomyopathy. So what happens with restrictive cardiomyopathy is it's a diastolic problem. There's reduced left ventricular compliance. The left ventricle becomes stiff because of the deposition of material within the myocardium. So restrictive cardiomyopathy may be idiopathic, but it can be secondary to infiltrative disorders. We've covered some of these infiltrative disorders already that can result in restrictive cardiomyopathy. So these are some examples, things that can cause infiltrative causes of restrictive cardiomyopathy: amyloid, sarcoid, hemochromatosis, non-infiltrative idiopathic diabetes. Then there are some other things like storage diseases. We've talked about Fabry's, and then some other disorders that might also result in abnormal compliance of the left ventricle that can cause restrictive cardiomyopathy. So the stiff walls prevent diastolic filling of the heart. And so in the early stages, the heart is not dilated. Sometimes the wall can be thick, especially if you have these infiltrative disorders. It can mimic clinically constrictive pericarditis because that can also impair diastolic filling. And so when you have infiltrative disorders, you can have thickening of the myocardium, but because of the high filling pressures, you can also have dilatation of the atrium. So here you have dilatation of the right atrium and left atrium in this patient with restrictive cardiomyopathy. You don't have to memorize this list, but We talked about some entities already, what's on your differential of left ventricular hypertrophy, hypertrophic cardiomyopathy, amyloid, Fabry's disease. Of course, we have hypertensive disease, aortic stenosis, athlete's heart. And then MRI can help differentiate some of these entities, and we've covered some of the ways we can use MRI already to help differentiate some of these entities that can cause left ventricular hypertrophy. Okay? So this patient has arrhythmia and systolic dysfunction. So we have various views. This view is, alpha tract or 3-chamber view. This guy, 2-chamber, and then here we have some 4-chamber views. Anything look abnormal? Yeah, and are you surprised? We've said there's systolic dysfunction, right? So ventricle is not contracting as well as you want it to. So the ventricle is somewhat hypokinetic, okay? So what do you want to see? Yeah, so remember when we're dealing with cardiomyopathies, that can give you a dilated, poorly functioning ventricle, right? We said there are 2 major types. There's ischemic and non-ischemic, and myocardial delayed enhancement can sometimes help you differentiate between them. So here are the delayed enhancement sequences, and what are the findings here? What does it show? Yeah, so here it's mesocardial, mostly mesocardial, right? Mostly along the mid-myocardium. Seems to spare the endocardium, right? So the endocardium is spared. So first, is this myocardial infarction? Why not?
It's not affecting the.
Well, it spares the endocardium. Also, it's in more than one vascular distribution, right? Usually infarcts will localize to a vascular distribution. So what's your differential for this? What could this be?
Myocarditis.
Yeah, so this could be a sequela of myocarditis, right? So even acute myocarditis, right, if the patient happens to have acute symptoms. So myocarditis in the acute phase can give you enhancement. In the chronic phase, you can have fibrosis from myocarditis, and that can give you mid-myocardial areas of abnormal enhancement like this. And we've talked about myocarditis, the sequela being a cardiomyopathy after myocarditis, right? Is there anything else in the differential? Chagas disease, although it's not the characteristic appearance of Chagas disease, right? We'll get back to that. Anything else? Well, sarcoid is certainly something to consider, right? Another thing to consider in your differential. And then what's the finding here on MR? What? No, it's not a PE, that's partial volume averaging. But it's averaging from what? Yeah, so the perihilar regions, right? Look at there's all this stuff in the perihilar regions, right? So there's some abnormal parenchymal opacities and maybe even adenopathy there in the perihilar region. So this is what you would expect to see in a patient with sarcoid. Yeah. Upper lobe changes, these perihilar changes there that you would see with sarcoidosis. Of course, it's easier on a CT scan, right? We can see the lymph nodes, lymphadenopathy there. There's a perilymphatic distribution of nodules, some perihilar fibrosis. So this is a patient with sarcoid who has cardiomyopathy secondary to sarcoid. So usually you won't have, if you're dealing with a test question, usually you won't have sarcoid and myocarditis in the same answer because the two can look very similar, right? They have similar characteristics on delayed enhancement. So unless there's some history that can help you differentiate, or some other findings. Sometimes even on MR, you can see the lung findings associated with sarcoidosis. Okay? So one thing that has been described for sarcoid is sometimes this enhancement pattern, this pattern of enhancement along the interventricular septum, especially more towards the right ventricle. So this has been described with sarcoid. It's supposedly a characteristic feature, but it doesn't always happen. Okay? Different areas where you can get enhancement with sarcoid, usually the presenting symptoms, so in a patient with sarcoid, right? So we have many patients with sarcoid. What is it that the clinician finds that would, that would have the clinician order a cardiac MRI? What would make the clinician suspect? This patient might have myocardial sarcoid. Most patients with sarcoid don't. But what is it that the clinician might find that would lead the clinician to suspect this might be myocardial sarcoid? I need to get an MRI. What is it?
Condition, arrhythmia?
Arrhythmia is the number one thing, okay? So in a patient with sarcoid, if there's an arrhythmia, right, so then the clinician would usually send the patient for an MRI to rule out myocardial sarcoid. So heart block from, remember, these are non-caseating granulomas that occur all over the body, and they can occur in the myocardium too. So if they occur in this region, they can affect the conduction system, so that can result in arrhythmia. Some other things, aneurysms at the base of the ventricle, sometimes sarcoid patients might have that. Sometimes they might have mitral regurg from involvement of the myocardium near the papillary vessels. Okay. But heart block, but arrhythmia is the major finding that would lead a clinician to send a sarcoid patient for MRI. Aneurysm at the base of the ventricle is somewhat unusual, but this can occur in patients with sarcoid. Okay. Sarcoid. It's important if you're imaging a patient for sarcoid to include T2-weighted images, because if there is active disease, that might cause areas, or it might show you areas of edema. So you might have some high signal areas. And many times that also correlates with the areas of abnormal enhancement. Okay, so it's important to include T2-weighted images in your protocol if you're evaluating a patient for sarcoid. Right? So this will affect, of course, your T1, T2. So what happens to the native T1? Increase T2, post-contrast T1, ECB. Yeah. Okay. So what you would expect from pathology, right? So sarcoid. By the way, there is another test that they can send patients for if they suspect myocardial sarcoid. That's illustrated here. What is that test? PET CT. But there's something you do have to remember if you're getting a PET CT on a patient and you want to evaluate the myocardium for sarcoid. What do you have to do? Why? So the patient preparation includes fasting for that, right? Why is that?
To make the heart resistant to glucose.
Yeah, because remember, you're competing with glucose metabolism, right? So when the patient fasts and you restrict the glucose, then the heart goes more towards oxidative metabolism for fatty stuff. And so you want to reduce that competition of the heart competing with glucose, because you'll see heart activity in many of your cases of PET CT, right? Well, how are you going to differentiate that from abnormal cardiac activity? So it's important that the patient is fasting if you're doing it looking at the myocardium, if you're using FDG glucose. Okay. All right. So 42-year-old with decreased ejection fraction on echo. What kind of view are we looking at here? Short axis view. When you look at the heart itself, does anything look abnormal? Yeah. Are you surprised? The ejection fraction is low, so maybe a little hypokinetic, maybe a little dilated. So we're not so surprised by that. Okay. Anything else look abnormal? Well, let's see. What else can we do? Here's a normal patient. So this is a normal patient. This is our patient, the abnormal patient. When you compare the two, what's different?
So the left ventricle wall is thinner than the other regions?
Tiny bit. Anything else abnormal?
Decreasing alveolar.
Yeah, look at the liver, right? What does that mean? Yeah. So iron deposition, okay? So, and look at the signal of the myocardium. Even the signal from the myocardium is less. Normally, the signal from the myocardium should be about the same as the signal from the skeletal muscle. If it's decreased, then you might suspect there's something wrong. But the liver is a big clue, right? You look at the liver and you notice that there's all this dark signal from the liver, then we have to suspect that there's iron deposition. So what are we going to do if this patient's on our MR table? What are we going to do? What?
T2 star.
Not in and out of phase, but T2 star weighted imaging, right? So what does T2 star weighted imaging allow us to do? Why are we going to do that?
To see how the signal.
Well, it allows us to quantify the amount of iron deposition, right? So we can do that with T2 star weighted imaging. So this patient also has a dense liver on CT, which no surprise there, okay? So You can evaluate it with T2 star. So what happens with T2 star weighted imaging is as you prolong the TE, the signal normally fades out, right? But in a normal patient, that occurs gradually. In a patient who has iron deposition, that occurs much more quickly. And so you can actually plot this to come up with a T2 time constant, right? And then there's a magic number for that T2 star time constant. What's the magic number?
I think it was
20.
20 milliseconds. So if it's less than 20 milliseconds, that implies that there is significant iron deposition to result in myocardial dysfunction. Okay? So in your patient with iron overload, you can see that the signal here decays much more rapidly than in the normal patient. So here the T2 star constant is 48 milliseconds, here it's 7.5. So if it's less than 20, that's the magic number, right? Then we have significant iron deposition here. We can diagnose that with MR. So what's going to happen to the patient then? If the patient has a positive study, what will they do?
That's the pre-Hypertrophy rate.
Well, yeah, but assuming that they have it, I mean, that's why you're doing the MR. You're doing the MR because it's known that the patient has hemochromatosis. They want to know if there's an involvement of the myocardium.
the patient chelated.
Yeah, so they'll treat with chelating agents, and what should happen on the follow-up exam? Yeah, the T2 star time constant should go up, and it tells you that it's working. Okay? So with iron overload, you can have a dark liver, dark myocardium, but the T2 star weighted imaging is very helpful. Right? Magic number is 20 milliseconds, and of course we can color code the images to show us, you know, where the number is below a certain threshold, so we can always do that. Look for the abnormality. So what's going to happen to the native T1? What? Who says increase? What's going to happen to the T2? What? Increase or decrease? Increase? Decrease. What happens to the ECV? Well, surprise. Iron causes decrease. Remember, iron causes the signal to decay. So it decreases the T1 and decreases the T2. It's an intracellular process, so the ECV is normal. Right? So you can use T1 mapping actually in addition to T2 star weighted imaging, you can also use T1 mapping if you're looking for iron deposition within the myocardium. And, you know, some studies have shown that these T1 values are more reproducible than T2 star. Some studies show that the T1 mapping is better than T2 star for looking at iron deposition within the myocardium. Okay? And it should cause the T1 to go down. This is, again, the exception to pathology. Usually pathology causes T1 to go up. Okay? All right. So, four-chamber view, myocardial delayed enhancement. What do we have? What looks it?
Subendocardial delayed enhancement.
Yeah, so there is this endocardial delayed enhancement. What about this part that's not enhancing? What is that? What's that thing? What? Infarct? Is that in the myocardium? It's not. So what is that? Thrombus. So are you surprised that somebody has delayed enhancement in the apex of the ventricle with a thrombus in there? No, you're not surprised by that because what's the most common cause of delayed enhancement? What? Subendocardial delayed enhancement, what's the most common cause of that? Infarct, right? So could this patient have an infarct with a thrombus at the apex of the ventricle? Why not? Well, is there anything else abnormal though? What about the right ventricle?
The right atrial dilatation as well.
Yeah, the right ventricle also has a thrombus here in the apex. And there's also subendocardial enhancement here. Okay? So my question for you, what lab test would be abnormal for this patient? Eosinophils. Right. So what is this disorder? Loeffler's endocarditis. So in patients who have hypereosinophilia, there are different diseases that can cause hypereosinophilia. But in patients with hypereosinophilia, The eosinophils release enzymes in the bloodstream, and then that can cause damage to the endocardium. That damage to the endocardium can result in endocardial fibrosis, subendocardial fibrosis, which causes delayed enhancement. And also that causes thrombus to form, mural thrombi. So mural thrombi with subendocardial enhancement, this can be a feature associated with Loeffler's endocarditis, and that's related to eosinophilia. Okay, so eosinophilic endomyocardial fibrosis or Loeffler's endocarditis. So these patients can develop mural thrombi and can have subendocardial enhancement because of the damage to the endocardium. So we've gone through the pathophysiology here. They can also have stiffness of the ventricular wall. So this is a cause of restrictive cardiomyopathy. Okay, so it can occur from hypereosinophilic states. There's some other rarer causes also that can occur in Africa. And so what can happen here is we'll have high signal on T2. You can have thrombus that forms there within the ventricle. And of course, that's going to be a little bit easier to see on delayed enhancement because the thrombus is not going to enhance. Okay. So there's an acute necrotic stage where you have tissue damage, a thrombotic stage where you develop layered thrombus, and a fibrotic stage which occurs later on. The patients can develop restrictive cardiomyopathy. So the take-home message, mural thrombi, subendocardial enhancement, think about, especially if it involves both ventricles, think about eosinophilic disorders involving the heart, Loeffler's endocarditis. All right, what kind of views here? Short axis here, and here we have four chamber. What's that going? So something funny looking about the right ventricle. So what's funny? First of all, what about the size of the right ventricle? Yeah, so the right ventricle looks dilated. And then what about the wall motion of the right ventricle? What would you say about the wall motion of the right ventricle? It's what? A little bit worse than that. Dyskinetic, yeah. So look how it's bulging out in systole, right? So you see these areas that are bulging out in systole. You said a magic word. You said it's kind of accordion-like, right? So it's got, you did say that, right?
I said uncoordinated.
Oh, uncoordinated, sorry.
I said accordion.
Yeah, you guys don't know what an accordion is anymore. So this kind of appearance, this crinkling of the ventricular wall, you see that crinkling there, kind of like an accordion? That's very characteristic for this disorder. So this is a disorder that causes dilatation of the right ventricle and causes dyskinesia, especially along the outflow tract, along the free wall of the right ventricle. Okay, and then this crinkling is very characteristic. What is the disorder? ARVD, arrhythmogenic right ventricular dysplasia. So this is fibrofatty replacement along the free wall of the right ventricle. And so this can cause arrhythmias, especially in young patients, and can be a cause of sudden death. Can be familial, so if one person in the family is diagnosed with this, they may send other patients for screening. So it's a rare cardiomyopathy associated with ventricular arrhythmia. It's said to cause 20% of sudden death in those less than 35 years of age. And it causes fibrofatty infiltration of the free wall of the right ventricle, autosomal dominant with variable penetrance. Okay. So what do we look for MR? There are major, what we call these major diagnostic criteria for MR that we use, although you have to realize imaging results alone is not sufficient to make the diagnosis, right? It also requires family history, ECG, Holter findings, histopathology, sometimes a genetic analysis. But there are these criteria that we look for in MR, these major criteria. What are they? Regional right ventricular, so one is qualitative and one is quantitative. The qualitative finding is regional right ventricular dyskinesia, right? So abnormal wall motion of the right ventricle. Then either of these quantitative findings, this ratio of right ventricular end diastolic volume to body surface area greater than 110 in males or 100 in females, or right ventricular ejection fraction less than or equal to 40%. So you look for dyskinesia and some quantitative evaluation of abnormal right ventricular function. All right, so that's what we look for MR to fulfill major diagnostic criteria. Other findings you might have in the a few years back, they talked about high signal along the free wall of the right ventricle. You might still see that, but that is not considered a major diagnostic criteria because it is too nonspecific. You might see aneurysms, diffuse thinning, dilatation of the right ventricle, hypokinesia, sometimes even abnormal delayed enhancement of the right ventricle. Those are other findings that you might also see. There's high signal on T1 weighted images along the free wall of the right ventricle. Right? So this can be seen in cases of ARVD, but this is not a specific finding. This is not considered a major criteria. Okay, so if you're asked an exam question on this, this is not a major criteria, although it can be seen in patients with ARVD. High signal in the free wall of the right ventricle from fatty replacement. Okay. Dyskinesia along the outflow tract, dilatation of the right ventricle with dyskinesia of the outflow tract. Right. That's what we look for cases of ARVD. And then, as I've said, this particular appearance, right, this crinkling here, very characteristic of ARVD if we see that. And then might also have some enhancement along the free wall of the right ventricle. Not a major criteria. Okay, those other things that we discussed are the major criteria. Right? What's wrong here? Yeah, it's hypertraveculated, right? So what do we call this?
Non-compaction.
Non-compaction of the left ventricle. What are complications of this? Thrombus formation, or you can get thrombi in there and emboli. What else? So cardiomyopathy, right, can be a cause of cardiomyopathy and arrhythmia, right? So those are complications of this. Okay. Criteria for making the diagnosis with MR. What's the criteria for making the diagnosis with MR?
More than 50% of the myocarditis.
No, not more than 50%. Where'd you get that?
Wasn't it more than?
No, that's for
the ratio
MDE.
of compaction?
That's okay. The ratio. What's the number? So what you do is, first of all, do you look at it in systole or diastole?
2.3.
2.3, right. Do we look at it in systole or diastole? And diastole. It's kind of different. In echo, they have similar criteria, only they look in systole. So in diastole, you measure the thickness of the non-compacted myocardium, and you compare that to the thickness of the compacted myocardium, and the ratio is 2.3. If it's greater than 2.3, that's criteria for non-compaction, as far as MR criteria. Okay. So you have the spongy, it's also called spongy myocardium. You have all of those trabeculations there. Typically affects more the apex of the left ventricle. Okay. And so abnormal persistence of that trabecular myocardium with deep intratrabecular recesses, and these are the complications which we have talked about. Most of the cases that we see now, because on echocardiography they see this and then they send the patient for MRI, most of the time it's asymptomatic, right? So I think what's happening now in clinical practice is if you see this, these are going to be asymptomatic patients, although there are patients that can be affected by this. But don't be surprised if most of the patients you run into are asymptomatic from this, just because they notice it on echo and then they send the patient for MR. Okay. And we talked about, so here's angio showing you that, and we talked about the criteria for diagnosis already for MR. The number is 2.3 at diastole. Okay. So on your dark blood images, you can see the trabeculations very nicely here, right? Very hypertrabeculated ventricles sometimes. And then here on your bright blood images, this is what we would use as our criteria for making the diagnosis at end diastole. It's typically more towards the apex of the ventricular non-compaction. Sometimes you might also have enhancement of the trabeculations on MDE. Okay, so this patient has an aneurysm at the apex of the ventricle, so we're thinking, this is an infarct. There's also delayed enhancement, infarct, but I'm telling you, it's not an infarct. What non-ischemic etiology could cause this? Aneurysm at the apex of the ventricle with abnormal enhancement. This is Chagas disease, right? So this we can see with Chagas disease. So it's a parasite, may be asymptomatic. Some patients can develop arrhythmias or heart failure, progressive myocardial fibrosis and aneurysms affecting the apex, infralateral, and inferior walls of the left ventricle. So aneurysms of the left ventricle that are non-ischemic in etiology can be a result of Chagas disease, and MRI will show the aneurysm, and you might see abnormal enhancement where the aneurysm is. Okay, so we can see that with Chagas. 63-year-old woman with chest pain, abnormal ECG, elevation of cardiac enzymes, right? So just given that history, the first thing you're thinking about is what? MI, myocardial infarction. So this is a two-chamber view. What do we see here? Any abnormal wall motion there? Yeah, look at the apex, right? So it looks like there's a hypokinesia or maybe even some dyskinesia at the apex. Does that surprise you if the patient's having an MI? No, of course not. Right? So let's investigate a little further. Of course, we confirmed here that dyskinesia at the apex, right? So it's confirmed there on this cath. So here we have T2 weighted images and delayed enhancement. Is this a myocardial infarct? No. Why not? There's no delayed enhancement, right? First, there's no delayed enhancement. And what's funny looking about the edema on the T2 weighted image? Well, why is this pattern not consistent with infarct? So here's our edema.
More than one.
Yeah, it's involving more than one vascular territory. Okay. So this is what an infarct looks like. That's the LED territory here. This is involving more than one vascular territory. So we have this patient who has myocardial edema, no delayed enhancement, dyskinesia at the apex of the ventricle. Your diagnosis is
Takotsubo.
myocarditis, or in this particular location, this is also self-limited. It can get better. See, it goes away. So somebody said, Takotsubo. Japanese part used to catch an octopus. Takotsubo cardiomyopathy. So it's a reversible cardiomyopathy. So we don't know, is it coronary spasm? Is it myocardial stunning from catecholamines? So there are criteria, diagnostic criteria. Not very satisfying, but there are these diagnostic criteria for it. But what do we look for? Dyskinesia in the apex of the ventricle, but it is not ischemic. It is not from infarction. Right? So there's no MDE. There might be edema. There might be some elevated cardiac enzymes, but there is no delayed enhancement. And it is self-limited. Right? So we might have edema, but no delayed enhancement. So it is not infarction. No perfusion defects either. But it's that typical location, the apex of the ventricle, where you get the dyskinesia. That should make you think Takotsubo. Okay. The differential diagnosis for acute chest pain, ECG changes, elevated enzymes, and normal findings on coronary angiography. Type 2 MI, that's a supply and demand mismatch, where the problem is there's a high demand and not enough supply, but it's not coronary artery disease. Myocardial infarction with non-obstructive coronary arteries. So SCAD stands for, I'm going to get a standing egg count over there. SCAD stands for spontaneous coronary artery dissection. Right? Emboli, vasospasm, recanalized coronary artery, any of these can cause infarct without obstructive coronary arteries. Acute myocarditis, infarction with a recanalized coronary artery, Takotsubo is on this list, microvascular disease also on this list. All right, so different things that can cause what simulates obstructive coronary arteries in a patient who's having chest pain and other findings that suggest that. Takotsubo, T1, T2, ECD. Oh, it's edema, right? There's edema here. So native T1 up, native T2 up, ECD up. Okay, so that's what we can see with Takotsubo.
Would you consider myocarditis without enhancement?
Well, yeah. You can have myocarditis without enhancement. You certainly can. So that's also a differential. It's kind of a form of myocarditis, really. I've given you this, which is a nice little graph that goes through the native T1 values, different diseases, and extracellular volume fraction. So remember the exceptions, those are the ones that might come up on exams, like, but usually pathology raises a T1, but exceptions to that are, right, Fabry's disease and, yeah, and iron deposition. All right, so that is our myocardial disease. Any questions? Well, study for the quiz next time. Sorry we started.